My name is Jong-sun Lee. JC I met at the urgent care during the clinical rotation because his abdominal pain. This case was challenging to me because he did not see any healthcare provider for 10 years. And JC is a 68 years old Asian man born in the 1957 and presented independently into the clinic. He is a good historian, and she complained that I have stomach pain after eating. Pain goes to the right shoulder. JC is a 68 years old Asian man complaining of right frequent RUQ pain, abdominal pain accompanied by the radiating pain to the right shoulder, especially after meal. He reports that the pain started 5 months ago as occasional light pain, but this morning at around 4 a.m. it got worse. The pain from his sleep. That he reports having a drink 2 glasses of Jack Daniel the previous night because he had the problem to falling asleep for 2 months. The first dose was 3 tablets of edible 200 milligram. However, the pain did not subside. Then he took another 4 tablets of edible for 200 milligram in the morning around 7 a.m. today. However, it's still dull, aching, and accompanied by nausea, blurring, gas, food intolerance. He has observed gray brownish stool and slight scleral yellowing. On the examination, the Murphy's sign is positive. She denied experiencing any fever, chilling, or vomiting. Intense of pain level. Pain is 4 out of 10 now, but it's up to 8 out of 10 after eating meals. Past medical history: no history of chronic illness, hospitalization, any surgery, medication, no prescribed medication. Only he takes edible whenever he has pain. No allergy to drug, full environmental pollen, and latex. Immunization is up to date. The substance use: the alcohol drinks 3 to 2 times a week with hard liquor, 2 glasses for 20 years. Tobacco: smokes one pack daily for the 40 years. Denies recreational drugs, caffeine, cups of coffee or months. And the family history: father died due to pancreatic cancer at the age of 59, and paternal mother has a similar symptom and passed away at the age of 59, like his father. There is no family history of gallbladder, gallstone, or liver disease. Social history: he is a retired mechanic and has a high school diploma from the high school. He lives alone in the single family home. His wife expired 20 years ago due to car accident. He is currently not in a relationship. Heterosexual, was not sexually active. Without STD history. He is Christian, going to the church occasionally. He wears the seatbelt, has no gun at home, and smoking detected in home. He has 2 grown sons who lives near him. ROS: general fatigue, no weight loss, no fevers, slight yellow sclera, and pain, nausea, bloating, light slow, denies the vomiting and constipation, diarrhea at this time, and objective vital signs: okay. BMI is 20.7, healthy weight, there is no weight loss. General fatigue, uncomfortable, no fever, chills, and the mild scleral aesthetic, soft tenderness in the RUQ abdomen, a positive Murphy's sign, and no rebound tenderness over the guarding. Otherwise, remarkable other physical systems and no pertinent recent diagnostic has been reported. Assessment: differential diagnosis. The primary diagnosis is the cholelithiasis and with cholecystitis. Presence of RUQ pain, a positive Murphy's sign, a post-predenal pain, the radiating right shoulder, slight scleral aesthetic, and the light brown stool is indicative of obstruction of the bile flow or inflammation of gallbladder by gallstone. Pancreatitis: The patient has a history of alcohol use or family history of pancreatic cancer. Likelihood is low without ready the efficacy pain and the normal vital sign. Biliary colic, occasionally pain followed by the fatty meals and now increasing in the severity indicate that it has gone further than colic. Peptic ulcer is the presence of epigastric abdominal pain and early satiety should alert the possibility of PUD, but no symptom of include vellus, anemia, melena, and dysphagia. Other diseases, the insomnia, patient reports that he has difficult to fall asleep for 2 months. Final diagnosis of the cholelithiasis likely was the chronic cholecystitis. Plan. Lab the CBC differential the CMP lab RFT. Basic laboratory testing in the form of the metabolic panel liver function and the CBC should be performed for laboratory test diagnosis of cholecystitis. Lipid panel high serum LDL levels and low level of HDL were significantly associated with increasing risk of biliary calculus. Amyloid reported to rule out pancreatitis. Imaging abdominal ultrasonography stat to evaluate the possibility of gallbladder wall thickening and dilation of ducts at the first line. Abdominal CT in case of inconclusive sonogram, the CT was intravenous to contrast the usually revealed cholelithiasis and increase the attenuate of bile and gallbladder wall thickening. Or there is a MRCP of abdominal if biliary obstruction is suspected. Therapy and MPO until diagnosis of imaging. Pain control is the total 30 mg stat and acetaminophen 1000 mg every 6 hours oral. Maximum daily dose is 3,000 mg a day as needed. Surgical evaluation consultation should be arranged to discuss possible laparoscopic cholecystectomy. Lamelectin 8 mg oral bedtime for insomnia. Patient education surgeon will likely diagnosis of gallstone and the potential inflammation to the patient. Past a potential risk associated with undergoing surgery. Avoid the consumption of fatty liver alcohol and side erection of NSAID. Edible. Smoking cessation, alcohol treatment counseling services are available. Follow referral and gastroenterology or GS as necessary after ultrasonogram. After discharge, follow up in the clinic and 48 to 72 hours. Return to clinic if symptoms get worse, fever, vomiting, inability to eat, drink, and the holistic approach and caring science. Once JC noticed the nurse was Korean, he was happy, but he did not visit the clinic because there is no Korean speaker in this area. JC is Korean American man who speaks Korean easier than English. He was provided with English to Korean translation for all his medical needs, including taking medication, exams, and testing. He followed the direction and instruction during the assessment intervention without hesitation or issues. James Watson theory includes 2 out of 10 critical processes, which emphasize the humanity and the transpersonal aspect of care. Actively listening to obstetrician's symptoms, progression, and the personal context during the assessments that help build a rapport with JC. The nurse adopted the communication skill with the same Korean speaker to ensure the clarity and respect, which is critical process number 4, developing and sustaining helping trust the relationship and the education risk of of NSAID overuse, I call impact liver gallbladder health was provided ensuring JC felt empowering to make informed decision by using culturally sensitive language and visual aid to ensure they understand what's involved in using task number 7, encourage engaging in genuine teaching and learning experience. The holistic care means treating the whole person, body, mind, spiritual, and context. The physical dimension conducting the comprehensive assessment provides a sign of possible cholelithiasis and cholelithiasis, addressing medication safety and the need of diagnostic imaging and level evaluation liver function was done. Emotional dimension, JC's sleep difficulty and reliance on alcohol suggesting underlying insomnia. These concerns were discussed and supportive resources, including behavioral health referral, was provided. Spiritual dimension, although the JC did not express spiritual concerns, I maintained the respect and dignified present, allowing the space for reflection, honoring his personal beliefs. The cultural dimension, as an Asian man, JC may underreport pain and delayed seeking care. He considered traditional health belief and ensured that my approach respected has cultural value and potential language barrier and offered interpreter service. By integrating Watson's caring processes and the holistic framework, I was able to support JCs and not only physically but also emotionally, culturally. This approach strengthened our therapeutic alliance, improved his understanding of his condition, and laid the groundwork for safer, more effective caring plan. Thank you for listening.